Olá, sejam todos muito bem-vindos. É um grande prazer tê-los todos aqui em mais uma live do Câncer de Mama Brasil, nesses tempos de Covid, trazendo informação relevante sobre o câncer de mama, discussão científica de peso com convidados importantes. E essa é a função do Câncer de Mama Brasil, tá trazendo informação e discutindo várias questões. Eu peço licença a vocês, nós vamos trocar para o inglês em função do nosso convidado. Peço antes só que não esqueçam de inscrever no canal, dar o like no vídeo e assinar o sininho para que esses vídeos possam chegar ao maior número de pessoas. Okay, so welcome everybody. We're very glad to receive you all here in another live of Câncer de Mama Brasil, which is bringing relevant scientific discussions to breast cancer specialists. Today we're very fortunate because we're receiving two very distinguished guests. Professor Terry Mamounas, that's a breast surgeon and medical director of the Comprehensive Breast Program of Orlando Health in Florida, United States, and the oncologist José Bines, who is a clinical oncologist at the National Cancer Institute and the Clínica São Vicente. So, you guys, thank you very much. We appreciate you taking your time and share your knowledge with us. Have we lost Professor Mamounas?
João, vamos falar em português um pouco. O
Ele
professor
saiu?
Mamounas acabou de me mandar uma mensagem que ele está tendo algum problema com a internet. O Ari está me ouvindo, ele vai entrar em contato diretamente com o celular do Mamounas e vai nos, assim que possível, reconectar o professor Mamounas, mas a gente tem aqui o Dr. José Bines, que é um dos grandes nomes da oncologia clínica brasileira e também um grande amigo nosso. Bines, o que você vai querer saber do professor Mamounas? O professor Mamounas, apesar de cirurgião mamário, ele tem produzido uma quantidade relevante de publicações relacionadas à parte de oncologia clínica, com assinatura genética, com hormonioterapia, com terapia anti-HER2. Você vê ele hoje mais como um pesquisador na parte da oncologia clínica mesmo? Ou você vê ele mais como um pesquisador na área de cirurgia geral? Cirurgia mamária, perdão.
Bom, boa noite a todos. Primeiro, queria agradecer Guilherme, João Henrique, pelo convite. Um prazer estar aqui, participando desse evento, que eu acho que virou já um evento tradicional e importante dentro da oncologia de mama no Brasil. É interessante, porque o Terry Mamounas é um cirurgião de mama, mas acho que, como muitos vem acontecendo aqui no Brasil também, tem uma formação mais ampla e não se limita somente à cirurgia. Tem uma visão geral de tratamento sistêmico e até mais, desde questões talvez ligadas a câncer de mama inicial e eventualmente até câncer de mama localmente avançado também. Ele é um membro importante do NSABP, né, um dos grupos que mais produzem e mais produziram, acho que, estudos muito significativos do ponto de vista desde quimioprevenção em câncer de mama, passando por cirurgia conservadora até tratamento sistêmico. Então, ele é um dos líderes do grupo atualmente, né? A gente estava conversando um pouco antes, acho que seria interessante ele antecipar para a gente o que vai acontecer agora na ASCO, né? A gente vai ter um congresso americano de oncologia clínica virtual, com apresentações que permanecem importantes. A gente tem desde uma sessão plenária que envolve cirurgia de câncer de mama dentro do estadio 4, estudos, tem uma atualização do estudo Catherine, de neoadjuvância, e tem um estudo também original que demorou muito tempo a ter resultados, que é um estudo de carcinoma in situ HER2 positivo, se trastuzumab, se Herceptin tem um papel. Então, acho que seria interessante se ele puder falar um pouco para a gente a respeito disso. Eu acho que seria interessante a gente ouvir dele também como que ele, como um cirurgião de mama, se sente a participação e viu ao longo do tempo mudar essa atuação. Acho que é interessante também a gente ouvir dele. A gente, né, tem ouvido, há pouco tempo teve a Andrea Barrio, que deu a experiência de Nova York, um dos lugares possivelmente o mais atingido por coronavírus. O Terry está no sul da Flórida, e acho que a perspectiva vai ser um pouco diferente, né? Acho que um local que não foi tão acometido pelo coronavírus, e dessa forma as questões ligadas à cirurgia de mama e ao tratamento de câncer de mama como um todo não foram tão afetadas como em Nova York.
A gente viu ele falando um pouquinho, que infelizmente ele não pôde adiantar para a gente, né, essa questão do câncer, o carcinoma in situ e Herceptin, mas provavelmente já logo a gente vai ter esses resultados. E ele estava adiantando para a gente essa questão que a gente pode começar a conversar com você, Binis. Eles não foram tão atingidos assim, estão fazendo cirurgia, mas o programa de screening deu uma parada, né? Então, a expectativa suas como oncologistas, e especialmente aí no Rio, né, que o problema está tão sério, estão esperando o aparecimento de tumores em estágios mais avançados em função dessa falta de rastreamento que nós estamos fazendo em geral?
Eu acho que essa é uma preocupação, né? Uma preocupação que não vai só para oncologia, e isso tem se visto, tem dados já publicados, né, nos Estados Unidos, em particular em Nova York, como situações de doença coronariana, acidente vascular cerebral, que estão sendo retardados, né? As pessoas não têm procurado o hospital, e o número, tem um dado recente interessante também, que o número no caso nos Estados Unidos, né, quando tem a chamada 911, que pessoas já com parada em casa aumentou muito, por exemplo, do mês de fevereiro para o mês de março, por exemplo, em Nova York. E eu acho que câncer é a mesma situação. Acho que o Terry se juntou agora e pode falar para a gente. And Terry, talvez tenhamos perdido ele, mas eu fico essa preocupação, sim. Quer dizer, a gente tem pacientes que estão deixando de fazer rastreamento. Eu acho que pessoas, além disso, que têm lesões palpáveis, que eventualmente estariam procurando o atendimento médico, e com medo, né, da situação como um todo, medo da infecção, estejam retardando. Então, fica a preocupação, e a gente entende que tem subtipos diferentes de câncer de mama que merecem abordagem distinta. Então, se a gente está falando de um tumor indolente, receptor hormonal positivo, baixo grau, essa vai ser uma abordagem que provavelmente esse tempo não vai alterar muito, mas provavelmente triple negative, HER2 positive disease, which has a more worse outcome. We're likely to see maybe more advanced disease. Terry, maybe you can comment.
Okay, Professor Mamounas, glad to have you back.
Yes, thank you. I
probably he was not following us.
Not from the beginning, unfortunately.
Okay, we're just talking about how we're going to see more advanced cases now because of lack of screening. But perhaps we can jump into the issues that we have programmed for this evening, which is we're going to talk about the genomic assays in the neoadjuvant setting and extended hormone therapy. And I would like to ask both of you, firstly, in this neoadjuvant setting that we define candidates based on intrinsic subtypes, based on immunohistochemistry, help us understand a little bit how this genomic assay can help us better select the patients for a neoadjuvant therapy, please.
So I can actually start if you can hear me. Can you hear me?
Yes, we can.
So I think the main way that we've used genomic assays to make decisions in breast cancer today, as you know, is for the ER positive, HER2 negative cohort, because most of the decisions for those with either triple negative disease or HER2 positive disease are pretty much automatic in terms of treatment. Although, of course, there are genomic assays that reclassify subtypes. But the majority of the genomic assays we use for the ER positive, HER2 negative. And there, I think the key question that we can answer today, or potentially help us today, is can we select patients that actually need or benefit from chemotherapy? Now, I think again, in the era of this COVID epidemic, one of the issues that we were faced, as you probably know, is that we were concerned that hospitals may be overwhelmed. We tried to impose, obviously, social distancing and stop the elective procedures. And one of the concerns was, can we safely perhaps delay the care for patients with ER positive, HER2 negative breast cancer, potentially delay surgery until a time where surgery can be performed safely. And obviously, one of the potential ways to bridge this was with neoadjuvant endocrine therapy, or sometimes neoadjuvant chemotherapy. And of course, for triple negatives or HER2 positive breast cancers, neoadjuvant chemotherapy is well established, and we temporize with that in this epidemic. But for the ER positive patients, I think there is a question of selecting those that potentially will not benefit from chemotherapy, and potentially we can temporize them with neoadjuvant endocrine therapy, or vice versa. If we know that the patient will benefit from chemotherapy, then maybe do neoadjuvant chemotherapy if the patient was a candidate. And obviously, genomic profiling can be used to help us with that, particularly, as you know, of course, Oncotype DX is a test that actually predicts benefit from chemotherapy or benefit from endocrine therapy. So patients with low recurrence score have significant benefit from endocrine therapy, adjuvant endocrine therapy, and by extrapolation, also potentially neoadjuvant endocrine therapy. And those with high recurrence score can benefit from chemotherapy, and then they can benefit from neoadjuvant chemotherapy. So some of the guidelines that have come out in this era of the COVID pandemic as to how you handle ER positive, HER2 negative patients with newly diagnosed breast cancer dictate that sometimes you'll obtain the genomic profiling test before surgery to help you sort of guide the patient. And that's a concept that we've talked over the years, but has never really caught on to become standard of care, because a lot of these patients will operate, we see what's going on with the nodes and the breast, and then we do the genomic testing in the adjuvant setting. But I think that presents a good opportunity to actually triage patients if you need to, and use neoadjuvant endocrine therapy for those with a low or intermediate recurrence score to temporize, and then go to surgery at the time that you can do that, and eventually then decide after surgery whether the patient needs anything more, although you already have had the genomic profiling test to guide you. And of course, there are studies that show better response to endocrine therapy for low intermediate recurrence score patients. And of course, studies that show more chemotherapy benefit, as well as pathologic complete response, higher pathologic complete responses for patients with a high recurrence score. So that's one way that you can actually use this information to temporize at this time.
Binis, you want to comment on that?
Yes, I think that we talk a lot about neoadjuvant endocrine therapy for a long time, and it has been very underused. And maybe one of the improvements we may have after the pandemic will be in the increase of neoadjuvant endocrine therapy. Saying that, I think that it's still a concern. I think we can consider the genomic test, but I think that we miss a little bit in terms of data to give us support into that. I think maybe with the results from the responder, once we know that even patients with positive lymph nodes with a low recurrence score do not benefit from adjuvant chemotherapy, I think this may be a missing link. As we're talking about neoadjuvant therapy, we don't have the precise information of lymph nodes that we have when we do in the adjuvant setting, where we have a pathologic response, a pathologic information in terms of lymph nodes. So I think this is still a gap. that responder may, with the results, may help. One other consideration, I think, and there's data, and I think we're talking about Brazil and different scenarios, would be the Papist Score as well, which has been validated. It's simpler, and it involves the tumor size, node, ER status, and Ki-67 at the time of surgery. And patients who got endocrine therapy and a low Papist score at the time of surgery do quite well, and a very, very small chance of benefiting from chemotherapy. So just to highlight that there are different ways, and I think something that we should keep in mind.
I think we can come back to that when we jump into extended hormonal therapy. But concerning node positive data, don't you think that the MIND-ACT set of data doesn't give us a hint of what's happening in low score genomic assay patients with node positive?
You mean in terms of benefit from
do you
chemotherapy?
think we have already some in terms of low risk patients in genomic assays to forego therapy actually in node positive cases?
It does that in the adjuvant setting for sure. I mean, it selects a group of patients with high clinical risk but low genomic risk that do well, and there doesn't appear to be significant benefit from chemotherapy for that group. So from that standpoint, you can use it. It doesn't have the same sort of information that the recurrence score gives us in terms of endocrine therapy benefit and chemotherapy benefit, because even that group did not benefit from chemotherapy. You would assume, of course, if they're ER positive, they will benefit from endocrine therapy, and then you could take them through the neoadjuvant pathway. And I'm talking about just if you want to make the decision who to treat with the neoadjuvant endocrine therapy.
Professor,
in the neoadjuvant setting. Oh, go ahead. Go ahead.
I don't have still. We didn't have any question from the audience yet, but I have a question. Is there a limit when you do Oncotype DX in the decision making about adjuvant chemotherapy? For example, is there a size limit of the tumor? Which is this size? Because we know that we prefer not using that with axillary positive disease, but I've never seen a limit between in the trial. Maybe 5 centimeters, maybe 4, maybe 3. We are not used about that.
So you're talking about the large tumor size. Obviously, there is a limit on the lower part.
A size limit?
Yeah, I mean, obviously there weren't a lot of patients with tumors over 4 centimeters in the trials of validation of the Oncotype DX. In the B14 trial, there were a few patients. So it's hard to extrapolate. But you can also extrapolate it, as you mentioned, in the way that if we start using it for no positive patients, who obviously have a little bit more risk, it's probably not unreasonable to consider it with somebody, let's say, has a 5 centimeter tumor with negative nodes. So we've been using it. We don't necessarily make a discrimination for that. The fact is, of course, that patients that have larger tumors, even with a low Oncotype score, they would have higher risk for recurrence compared to a patient with a small tumor and a low recurrence score. So that much is clear, that the inherent size as well as even nodal status still plays a role, even if your Oncotype test is low, intermediate, or high. Okay.
We have 2 questions from the audience. The first one is Carlos Gustavo Kripa. He's asking, in the COVID-19 scenario, without genomic tests, how to decide between a neoadjuvant chemotherapy or hormonioterapy in locally advanced breast cancer? You don't have genomic assays.
Right. That's a good question. And there, of course, I would use traditional criteria, namely the size of the tumor is important, of course, but grade is also very important. subtype, I mean, for patients with, let's say, lobular carcinoma, we feel more comfortable with neoadjuvant endocrine therapy. But for lower intermediate grade tumors, that's a temporizing approach. For a high grade tumor, I'll be more comfortable either going to surgery if possible, if I didn't have a genomic assay, or trying to get a genomic assay to help me. But I think you can temporize with traditional clinical pathologic factors.
Okay. And there is another question. Leandro Jonathan Oliveira, would you recommend genomic testing in the neoadjuvant setting to premenopausal women with ER positive, HER2 negative breast cancer?
Yeah, that has been actually more of a controversial point, because neoadjuvant endocrine therapy has not been used so much in premenopausal women. When you look at the data with the recurrence score, particularly from TAILOR-X, we know that patients with a low recurrence score do well, whether they're premenopausal or postmenopausal. We know there is a little bit more benefit from chemotherapy, though, in women under 50 with recurrence score of 16 and higher, versus in the postmenopausal over 50, 25 and higher. So there is a difference. So you have to you can use the test, but how you're using it will depend on the score, and you maybe use it a little bit differently in interpreting somebody as a premenopausal versus postmenopausal.
Excuse me, Professor.
However, yeah.
Do you prefer to use 50 years old as a limit between the number 20 or 25, or premenopausal or postmenopausal status?
Yeah, I mean, I think that much is not very clear, but the TAILOR-X data were mostly with age, because menopausal status, although technically was a significant predictor, age superseded that when it came to age and recurrence score. So we typically use age. However, if there's a 52-year-old woman that is still premenopausal, you could make the argument to treat her as a premenopausal patient as under 50. But in general, we use 50.
On the other hand, if you have a 48 women with menopausal status,
yeah, I would feel very comfortable treating a 48-year-old as in a postmenopausal patient, over 50. Yeah.
João Bines, may I ask you some more questions from the audience, or do you want to?
Let me just make one a technical question about the technical aspect of genomic assays in the neoadjuvant setting, because I don't know, usually when we do genomic assays in the adjuvant setting, the pathologists would look for an area in the tumor that they see more proliferation to sample the DNA in order to send it for the genomic assay. So when we do the neoadjuvant setting, we don't have this the chance to do that, because we're just taking a sample from the core biopsy. So how can we deal with that? How much can we trust the genomic assay done by a core biopsy, please?
Yeah, I mean, I think that's a good question. And in general, studies have shown good concordance between the recurrence score when done on a core biopsy versus when done on the surgical specimen. But you're right, there are some areas of the tumor that may have a little bit more recurrence score. Even though studies in preparation for the recurrence score had shown also that when they took a tumor, intra-tumoral variability was actually pretty low when it came to recurrence score. In other words, when they took a tumor and tested different parts of the tumor, the recurrence score results were similar. So at this point, I would feel still comfortable using the core biopsy. And of course, usually there's a pretty good yield from that. About 97% of the times will yield the recurrence score result. But I think you have to keep in mind that there could be some heterogeneity. But I guess at this point, that's sort of the best we can do if we wanted to temporize and not take the patient to surgery.
Bines, you are free to interrupt us whenever you want, please.
Okay. I think just one comment in terms of endocrine therapy. I think we had important changes in endocrine therapy over the last few years with the addition of the CDK4/6 inhibitors. So I think the anticipation is that, and there are some studies that are already published, small studies, but The anticipation is that the combination of endocrine therapy with the CDK4/6 inhibitors will have, as has been shown in the advanced setting with improved survival and long PFS, we likely will have a better outcome in the neoadjuvant setting as well. So I think it's something interesting to look forward for this combination and for the upgrading of the endocrine therapy as a neoadjuvant strategy.
A good point, yeah.
We have another question here from our audience. This is a friend, André Matar. He's asking, if you had a patient, luminal T2N1, with access to genomic test, which one would you prefer?
Oncotype or MammaPrint?
Or
yeah, I mean, I think if your decision is to try to temporize and do neoadjuvant therapy and delay surgery, I would still probably do an oncotype, because I think gives you information on endocrine sensitivity and chemotherapy sensitivity. If you do it in the adjuvant,
yes,
in the adjuvant setting, you can use MammaPrint as well, because that is the indication for patients with positive nodes. And then you're looking for low risk of recurrence to avoid chemotherapy.
There is another friend asking us, Nancy Ferreira, what's your opinion about using genetic tests in the staging patients with breast cancer? In fact, it's not Nancy, is her husband, Darley. He's using, they are two breast surgeons. He's using her ID.
So we're talking about genetic testing for inherited predisposition, I assume.
No.
Genomic testing for staging.
Yes, genomic testing for staging in TNM. I think there is a place for oncotype.
Okay. Yeah. Yes, and as you know, for the 8th edition of the AJCC includes Oncotype DX as part of the staging, and for patients with non-negative ER-positive breast cancer, the Oncotype can change the ultimate prognostic staging, not obviously the anatomic staging. So we use that information where we have it to completely stage the patient pathologically. We insert the Oncotype DX results. But that's for the non-negative patients, ER-positive. But as you know, also grade and ER, PR, and HER2 status play a role in the prognostic staging right now.
Another question, Leticia. Do you consider core biopsy sampling reliable for the evaluation of the genomic assays?
This has already been answered, I guess.
Yes, I think. How long should you wait for a genomic test? Pablo Barrios. How long should you wait for a genomic test in a neoadjuvant situation? Is it practical? Should you start endocrine therapy and change it to chemotherapy? It's Pablo Moura Barrios who asked it, Ari. I think it's on this question. Yes. So, do you understand the question, Professor?
Yeah, I think it's regarding the time that you may waste to do the genomic assay before starting neoadjuvant chemotherapy or hormonotherapy.
Sometimes here in Brazil, we take about 1 month and a half to have the test.
Yeah. So, right. I think in this era, if you wanted to temporize, it's not unreasonable to start back that is high risk. Then you can switch to neoadjuvant chemotherapy at the time. In the US, we usually take 7 to 10 business days, so a couple of weeks. So by the time you do some staging studies and everything,
Professor,
it should be back. But you can do it the way I will start with the neoadjuvant endocrine therapy as you wait.
Can I ask you a personal question? I have a friend with 41 years old. She have a breast lump, and she performed a core biopsy, and she have invasive breast cancer with ER/PR very, very weak, 2%, and HER2 strongly positive, three crosses. And the tumor size is 1.6 in the echogram, and after the vacuum assist biopsy, it is 1.3 in the MRI. No sentinel nodes palpable or in the images. Are you starting her treatment with chemotherapy, with HER2 blocking, or are you starting with the surgery? Binis.
Okay. Are you there, Terry? Well, I think this is a situation where
general for her to prefer the neoadjuvant approach for
we are hearing you, Professor.
Yeah, you're just breaking out sometimes, so we were not sure if you were there. But carry on, please.
Are you talking to me or to Jose?
Jose can start. Sorry for my cough.
Okay.
It's not coronavirus, but sometimes I have it. Binis, please.
Well, I think it's in the this size, tumor size in the edge. We usually assume that T2 tumors more than 2 centimeters or positive lymph nodes are candidates for neoadjuvant therapy, either triple negative or HER2 positive disease. It's possible that with the Catherine results, we are moving a little bit to the lower size to provide the patients with lower tumor size the benefit of adjuvant therapy in terms of residual disease. But at the same time, I think that we are over-treating a lot of patients that would otherwise fit the APT trial that would have just weekly Taxol and Herceptin and would do remarkably well over time. So I think it's in the edge. I think being maybe a young patient and
the worst, Binis. She's a doctor.
Mm-hmm.
She's a doctor. She have 41 years old. The tumor size is 1.6.
Yeah, I probably would talk to her and consider neoadjuvant chemotherapy with dual HER2 blockade, although she needs to understand that likely she will get a pathological complete response, and maybe it is over-treatment for her. But I think we would consider that.
Do you agree, Professor Mamounas?
Yes, I mean, I think we, in our institution at least, we treat patients with T1C and higher with neoadjuvant therapy if they're triple negative or HER2 positive. I think the bigger decision, as Jose mentioned, is whether you do dual antibodies or not, because obviously the approval is for tumors over 2 centimeters or no positive. So this, but on the other hand, this patient could use a regimen with single anti-HER therapy by giving it in the neoadjuvant setting. I have treated some patients, probably older patients though. We have treated them with the APT regimen, but you can do it in the neoadjuvant setting. If they get a PCR, then fine. If they're not, you can always offer them TDM1 at a time. So, but in this young 41-year-old patient, I probably would be a little bit more aggressive. We know that with dual anti-HER therapy, she probably has close to 80% chance of a pathological complete response, if assuming she's ER negative, HER2 positive. So I would discuss with her whether she wants to take a dual anti-HER therapy. That would be over treatment. Another option would be also TCH, taxotere cyclophosphamide. I mean, taxotere carboplatin and Herceptin as a single, single anti-HER therapy. So I think you have a couple options, but I would in general, favor the neoadjuvant approach. So I can see, first of all, if there is downstaging, if she gets a pathological complete response, and being able to offer her the Catherine regimen if she doesn't.
We have a question here from the audience, Guilherme. It's from César Cabello, surgeon in Campinas. What is your opinion about the use of PAM50 as an assay to CD4/6 inhibitor plus aromatase inhibitor as a neoadjuvant hormonal therapy?
I'm not sure. I mean, obviously with a PAM50, you can categorize the patient into luminal A, B, or obviously this is going to be a near positive patient, I will assume. But I'm not sure of any data. Maybe Jose can chime in terms of making the decision to use a combination of a CDK inhibitor and endocrine therapy. I think obviously if you have a luminal B patient, maybe you want to do that, but I don't know of any particular data.
Yeah, outside of a clinical trial, I wouldn't offer the patient this therapy. I think we don't have data to support that at this point in time, showing that the addition of the CDK4/6 inhibitor in this setting will lead to an improvement in terms of pathological complete response or lower Papist score, or even a prolonged disease-free survival. So there is associated toxicity with it. There's a cost issue related as well. So I think we need more data before embarking into that therapy.
And also, Dr. Maximiliano is asking, is there any clinical or research benefit in performing genomic assays on the residual tumor after neoadjuvant chemotherapy?
I would say no, because we just don't know what it means. And there will be some data from the Catherine trial looking at the HER2 status in the surgical specimen. But it's very hard to make treatment decisions because there are very few patients that change their status, for example, from HER2 positive to HER2 negative. Obviously, we do traditional receptors after neoadjuvant therapy for all our patients, and we see sometimes changes. But in general, for example, as I said, in a HER2 positive patient, I would treat them still as HER2 positive, even if they show to be HER2 negative in the final specimen. The opposite doesn't happen that often, but it can happen as well, like a triple negative, potentially to have a HER2 positive residual disease, in which case maybe you can consider something like TDM1, but again, very much uncharted territory in terms of what you do.
Yeah, we have another question regarding what we expect after neoadjuvant therapy. This is a question from Leticia Neuschwander. It's a great oncologist here in Belo Horizonte. If core biopsy oncotype was low risk, and after 6 months of hormonal therapy, surgical results showed lymph node involvement, would you do chemotherapy? Because we don't have yet the responder results. So she did hormonal therapy, and then there was a note that we were not aware. There was positive. What to do next? Chemotherapy?
João,
So
I'd like to hear in the next questions, if possible, the José Bines' opinion also, because okay, Bines, after Professor Mamounas, you can give us your opinion in these cases.
Yeah. So, I mean, if the lymph node involvement is minimal and the recurrence score is low, in the range of under 18, I would still feel comfortable continuing with the endocrine therapy and avoiding chemotherapy. I agree that we don't have the responder results, but there is a lot of information to suggest that patients with 1 to 3 positive nodes and low oncotype scores do very well. And so far, no study has, albeit it could be a retrospective of a prospective clinical trial, such as the SWOG trial, even the NSABP-B28, no study has shown any benefit for patients with a low recurrence score, whether they have no negative disease or no positive disease with 1 to 3 positive nodes. Well, you can argue even with more nodes, but then obviously, if there's 4 or more positive nodes, people will be very much inclined to give adjuvant chemotherapy. So I feel pretty comfortable, particularly in a postmenopausal patient, if the recurrence score is low, even with 1 to 3 positive nodes, to withhold chemotherapy, with a discussion with the patient, of course, that we don't have the definitive answer.
Binis?
Yeah, I think this is one of the difficulties of giving neoadjuvant hormonal therapy to patients. Once you get surgery, an unexpected number of positive lymph nodes. And I think this is a territory that we haven't been through. We don't know exactly if the meaning of a surgery first and then having the pathology report and a genomic assay showing, like, for example, that this is a low risk and a less benefit from chemotherapy means exactly the same as giving hormonal therapy in the first place and then getting the lymph node. So I would feel uncomfortable. I understand your point that if it is a low oncotype and if it's just one node, we can talk to the patient, but the patient, I think, needs to understand that there's very limited data into that.
Right. And usually these are the patients who, I mean, who as many nodes as they have before neoadjuvant endocrine therapy, they will have after, because pathological complete response for these patients is very uncommon. So it's not necessarily that the patient progressed. I would think that this patient always had, 1 or 2 positive nodes. So I don't think it changes that much, that the fact that, we gave them neoadjuvant. I mean, assuming also that, let's say, the primary tumor shrunk and you see some evidence of response, right? Not resistance all the way to neoadjuvant endocrine therapy.
Professor, I'm changing the subject.
Guilherme, just one more point.
Sorry,
I think that for the whole audience, I think we have people coming from different backgrounds, and I think when we're talking about neoadjuvant hormonal therapy, I think it's important to set the times, and usually the longer the treatment, the longer the benefits you get. So we usually state at 4 to 6 months, and I think, as Terry mentioned, we don't anticipate PET-CR. The PET-CR is quite low as compared to chemotherapy in other tumor types. And but one word of caution, I think, is that the patient needs to be obviously followed up, and if there is any evidence that the tumor is growing, we should stop hormonal therapy and likely take the patient to the operating room.
Right.
Okay.
And if I can make a quick point as well, in the year of COVID,
you can do everything.
If you now, let's say, you are past the peak and your hospital is starting to do elective procedures, and you have patients that they receive neoadjuvant endocrine therapy, I don't see anything wrong to interrupt it and take them to surgery. I mean, it's fine that they're going to get more response as you go to 6 months. But if you're uncomfortable, or if the patient wants to have surgery, it's fine to stop, go to surgery, and then make adjuvant therapy decisions at that point.
And as a follow-up question, a person from the audience.
João, yep. I'd like to ask a technical question to Professor Mamounas about surgery in the neoadjuvant setting. Normally, we receive the patients with locally advanced breast cancer. The patient first go to a gynecologist most of times, and they perform a normal core biopsy without a clip. And are you going to, when this patient arrives at your office with a positive biopsy, invasive breast cancer with axillary palpable mass, are you going to do a new biopsy to put a clip inside the tumor, or to put a clip in the lymph node in the axilla, or do you think that it's not necessary?
So for patients that get neoadjuvant chemotherapy, particularly triple negatives and HER2 positives, we definitely will put a clip both in the breast and in the axilla, even if the patient didn't have it before. So we'll do another biopsy, not a biopsy, but we're just going to put a clip because it's very important to localize. For neoadjuvant endocrine therapy, you could probably wait it out a little bit and see what kind of response you get, and if you can see the tumor up front. because most of the times you're not going to get to the point of complete radiologic response. So if you want to wait and in another couple of months re-image the patient, if you see a good response, then that would be a time to put a clip. But in general, you can probably find out where the tumor was in somebody with ER-positive disease and neoadjuvant endocrine therapy. But if you give neoadjuvant chemotherapy, even for ER-positives, I would tend to biopsy, put a clip in again.
Do you prefer a seed with a radiation seed in the axilla, or are you using a normal clip? Because sometimes we use this normal clip and we don't find it during the surgery.
Right. So what we do in our place, and I don't know if you have the ability in your place to do that, but we use the SavvyScout as a localization method. So we essentially, at the time of surgery, right before surgery, we'll go back to where the clips are and we'll put SavvyScout both in the breast and in the axilla. And we use the SavvyScout probe to find the axillary node.
Okay.
But you can also use the radioactive seed.
Any other tracer?
We don't use it, but obviously others do. Radioactive seeds are available. You can use the MAC trace as well, the MAC seed to find the node. So we find that these wireless localizers are actually very good, and we'll do it both in the breast and in the axilla.
And do you also do the sentinel node marking with technetium and blue dye, or no, in these cases?
Correct, yes.
So that's my question, Terry. Maybe we lost you?
I think we lost Professor Mamounas. He's coming back. A gente pode falar um pouco em português, Binis, até ele voltar aqui.
Tem uma pergunta aqui da plateia, vocês querem ouvir então, Binis?
Claro.
Pergunta da Luciene, é uma paciente com câncer bilateral, do lado direito um tumor de luminal A de 9 milímetros, do esquerdo luminal B de 5 centímetros. E o Covid teste negativo e o plano de saúde negou o teste genômico. O que ela faz, cirurgia ou neoadjuvância?
Eu acho que o primeiro comentário, eu acho que é só a gente tomar muito cuidado nessa caracterização de luminal A, luminal B, baseado em imunohistoquímica. Né? Tem uma grande variabilidade de imunohistoquímica, tem em relação ao KI67, ainda mais quando a gente está falando de core biópsia, porque na periferia do tumor tende a ter KI67 mais elevados do que no centro do tumor, e tem uma variabilidade entre os patologistas no que cada um chama um determinado valor. Então, quando esses valores são muito baixos ou muito altos, tende a haver menos discordância. Então, acho que tomar muito cuidado nessa caracterização entre luminal A e B por imunohistoquímica, na verdade, a gente está falando de um perfil molecular, né, baseado no PAN50. E aqui a gente está fazendo uma transposição dos resultados de imunohistoquímica. Mas vamos imaginar que essa paciente tem um tumor de 5 centímetros e se essa paciente tiver um receptor hormonal muito baixo, né, eu acho que essa paciente vai ser candidata à quimioterapia e oferecer para ela a quimioterapia antes ou depois da cirurgia, provavelmente não vai fazer muita diferença e vai possibilitar que ela tenha uma cirurgia conservadora.
Vamos voltar para o inglês, que eu acho que ele já está ouvindo. Pode continuar, professor.
Okay. Hi, Terry.
I'm sorry, guys, I connected somehow.
A patient with a bilateral tumor, with a 9-millimeter tumor on the right side, and a 5-centimeter tumor on the left side. Both are ER-positive, HER2 negative, and the smaller one, the 9-millimeter, seems to be more luminal A-like tumor, and the left tumor, the 5-centimeter, more of a luminal B tumor.
Should we go for surgery or neoadjuvant therapy? Could you get the case?
So bilateral breast cancer, ER-positive, HER2 negative?
Bilateral, the bigger one, luminal B.
HER2 negative. The right side is a 9-millimeter tumor, and the left side is a 5-centimeter tumor.
I'm sorry, I can't hear. What was the other side? I heard the first one.
A 5
half centimeter.
5 centimeter tumor on the left side. Voluminal B-like tumor.
I mean, you could use neoadjuvant endocrine therapy for somebody like. How old is the patient?
The person that's asking doesn't say the name, the age, so we don't have the age.
Luciene, Celeste, Teresa Cristina. Can you put this question on the screen, Ari, please?
Professor, perhaps your internet connection is not so good. If you turn off the camera, perhaps the audio would get better. How about that?
Okay. Yeah, I'm not sure why, but I'll do that. Yes.
Let's see if it works better.
Still has some static for whatever reason.
Yes, we are learning these new platforms. We are not so used to deal with that. It's hard sometimes. But don't worry.
To make
we
matters,
can understand you. We can understand you.
To make matters worse, let's assume that she's premenopausal. How about limits?
Most likely, I would treat her with chemotherapy, with neoadjuvant chemotherapy, with
for premenopause.
Young patient with a large tumor size, and I'm assuming that her hormone receptor status is she doesn't have like a IER or PR, so very likely she'll get benefit. So I'd rather treat her in the neoadjuvant setting and provide her the same chemotherapy with advantage of shrinking the tumor and providing her with breast conservation.
Can I ask a question, a practical one? Which size of tumor, triple negative tumor, do you prefer to send this patient to neoadjuvant chemotherapy? 1 centimeter, 1.5, or 2 centimeters? And 0.
Can you hear, Terry? So
I can hear you, but not very well, unfortunately. So I can't hear the question very well.
Okay, if you want to answer.
The question is a triple negative. What is the cut point in terms of tumor size to do surgery or neoadjuvant chemotherapy? 1, 1.5, or 2 centimeters?
Yeah, I mean, obviously, as I said, in our institution, we use T1C, so anybody over 1 centimeter can get neoadjuvant therapy, but most people will use 2 centimeter cutoff and above. So for triple negative patients, though, I mean, 1.6, 1.8 centimeters, as long as you are certain what type of chemotherapy you want to use, let's say for a premenopausal patient with 1.6 centimeters, you're going to use an anthracycline followed by a taxane in a dose-dense fashion, then you can do it certainly in the neoadjuvant setting. If, though, your decision may be different, if you know the patient has negative nodes versus positive nodes, namely maybe TC versus AC followed by T, then you can take the patient to surgery and try to make a decision based on the pathology report.
Okay. Bines, do you use...
Yeah, I totally agree. I think that if you decide to give neoadjuvant chemotherapy, you need to be sure that you are giving exactly the same chemotherapy that you would give in the adjuvant setting. Otherwise, I would like to have the patient go to the operating room and then decide upon the chemotherapy. So if you're talking about a premenopausal young patient with a tumor that grew and she noticed that, and even if it's like a 1.5, 1.6 centimeter, I would give, for example, ACT dose dense, either in the adjuvant or neoadjuvant. So I would take the advantage of giving her in the neoadjuvant setting, checking if she has residual disease, and giving her capecitabine in case there is no pathological complete response. If we're talking about an older patient with some comorbidities that would prevent me from giving her anthracycline, for example, maybe I would consider taking her to the operating room and giving the the whole treatment afterwards, once we have the precise size of the invasive tumor and if there is any lymph nodes compromised.
Okay, last question, you have asked the age. It was 65 years old. Do you change anything after that? This bilateral tumor?
Professor Mamounas, let's try something else. Can you hear us? Perhaps if you put your mic on mute, if you put your mic on mute, except when you're talking, you might not get this interference. Try to do that, please.
I will do that. Yeah.
And put your camera on. It doesn't change anything.
Try your camera on, your mic off. Yes. Okay.
Yes. I prefer to see you.
And when you talk, just remember to put it to take off the mute, please. Should we change to extended hormonal therapy? We have data from the Oxford overview that show us that luminal tumors, although they have a lower risk of recurrence, they carry this risk for a long time. And the question is, does the extending hormonal therapy can deal with this prolonged risk of recurrence, and how can we decide which patient should benefit from extending hormonal therapy? So can you just comment a little bit on in what stage we are now in terms of extending hormonal therapy, please? Either of you, please.
Go ahead, Terry.
Yeah, so in terms of extended endocrine therapy, we know that tamoxifen for 10 years is better than tamoxifen for 5 years. We know that tamoxifen after 5 years, an aromatase inhibitor after 5 years of tamoxifen is obviously important. And recently we have also demonstrated that longer duration of an aromatase inhibitor in patients that receive 5 years of an aromatase inhibitor also prolong disease-free survival. Now, besides one trial with tamoxifen, that the Atlas trial that showed the survival difference, all the other trials have shown no survival difference. So mostly it's a disease-free survival benefit, and it's relatively small. It's in the range of about 15% to 20% reduction, relative reduction. And in terms of absolute benefit, it's in the range of 4 to 5%. So obviously, there we're faced with a dilemma. How many patients do we need to treat to benefit? Few. In terms of the duration, what the data, I think, suggests is that ideally, obviously, if you get 10 years, you do better than 5. But most of the studies suggest that even if you get to about 8 years of total therapy, in other words, about 3 years of extended adjuvant endocrine therapy, you get most of the benefit, particularly as it relates to the aromatase inhibitors. So for tamoxifen, we don't have that information. We usually try to go for 10 years. But for the aromatase inhibitor, even if you get 8 years, I think you get the maximum benefit. The key challenge, of course, is to identify patients at higher risk that will benefit more from the treatment, whether the risk versus benefit ratio is better. How do you do that? Of course, patients with positive nodes, patients with large tumor size, high-grade tumors, all those have higher risk for late recurrence, as the meta-analysis has shown. But beyond that, we're trying to evaluate genomic classifiers as well to see if we can help predict risk of late recurrence, which actually, as you know, there are many commercially available genomic classifiers that do that, both the EndoPredict, the breast cancer index, even the Oncotype for high ER positive patients by the recurrence score. And also even MammaPrint has shown some data with the ultra low risk. So many commercially available classifiers predict risk of late recurrence, but one that up until now has been found to also predict benefit from endocrine therapy is the breast cancer index. And the breast cancer index data show that patients that have a high H/I ratio, which is part of the breast cancer index, seem to benefit a lot more from extended endocrine therapy versus those that have low H/I ratio. And that has been shown in the ATOM trial with tamoxifen, and also in the MA17 trial with the sequence of tamoxifen followed by letrozole. So we'll be evaluating some of these genomic classifiers on the material from the B42 trial, which we presented an update in San Antonio last December, and hope to be able to refine the algorithm and identify the best candidates for extended endocrine therapy.
Binis?
Yes, I think it's a decision that it's a daily decision we have in the office with the patients, and there are things that we need to consider. So as Terry mentioned, I think the tumor itself is important, and more so in the positive lymph nodes as compared to the negative lymph nodes, and other issues in terms of risk. They're exactly the same ones that the patient presented many years before. But I think that other issues need to be taken in consideration in terms of how did the patient take those years of endocrine therapy, how much side effects is the patient having, how much is the patient willing to continue, and other comorbidities or things that would limit the patient's life expectancy that should come into play as well. And I think one other issue I'd like to comment into that is that besides the genomic, there are some simpler ways as well. There is the CTS5 calculator developed by the British, and they have validated that into the postmenopausal women, not so well in the premenopausal, but they divide into risk 5%, 10%, and the patients who have low risk, lower than 5%, based on simple characteristics such as age, tumor size, number of positive lymph nodes, and Ki67, you could, in terms of grade, you could help you make the decision together with a patient in terms of continuation of the hormonal treatment beyond 5 or sometimes beyond 10 years.
So it may happen that the CTS5 indicates extension of hormonal therapy, and the ASCO guidelines says not to extend. If these two tools, they contradict each other, what to do? So the ASCO guideline says don't extend hormonal therapy. You use the CTS05, and they said extend hormonal therapy. What to do?
Well, I think this decision is not a black and white decision. I think patient's input is very key into the decision. How much the patient fears of having the cancer coming back, and at the same time, how many patients are counting the days when they finish up their hormonal treatment and they want to get rid of it.
Okay.
Sorry, my microphone was off. We have 1 hour. It was the time that we asked for the professors. In the name of our website, the Câncer de Mama Brasil, we'd like to thank you so much for your time, Professor Mamounas and Professor Binis. Thank you so much. We hope this pandemic time finish as soon as possible, so we can have you here as always we have. Thank you. We hope you stay safe and all your family. Thank you, professors. João?
Thank you very much.
Thank you so much, both of you. Any last comments, please?
So we hope to see
I would echo what you said. We all wish that this will finish quickly. There's some interesting data with a potential vaccine today, so we're hopeful that maybe there is some light at the end of this tunnel, but stay safe.
Yeah.
We have to do our part, be vigilant, and that shall pass. Hopefully, we'll hope.
We hope. Binis?
Thank you. No, just a pleasure to share this discussion, and stay safe, and hope to have new information coming up at ASCO in a few weeks.
Okay.
So everybody,
Thank you.
stay safe. Stay safe, and for the audience, don't forget to make the inscription in our channel, and give the like of this video, and see you again in the next live. Stay safe. Stay at home. Bye-bye.
Bye-bye.
Bye.
Thank you. Bye.
Thank you.